Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio, joined, of course, by my partner in crime, Dr. Dana Hawkinson, who we kindly refer to as Hawkeye, or the Hawk. Dana is our Medical Director of Infection Prevention and Control. Today we have two special guests. One is Rick Couldry. Rick is the VP of Pharmacy Professions and many other things. I can't even list all of them. He does a great job with us, as well as the Director of Microbiology, Rachael Liesman. Rachael is our testing person. She knows everything about testing, keeps our testing equipment up and running, and really keeps the whole health system up and running when it comes back to our testing response here at KU. But first, Hawkeye, let's get everybody updated. It was so good over the weekend. Not good. It was at least stable over the weekend. So I was pretty happy. And then I saw this morning.
Yeah. I was working Thursday and Friday, and I kept watching our census Saturday and Sunday, and was happy because we were still staying in that 90s.
And you felt like we'd hit a new plateau. Yeah. That was good. Equilibrium. But then something happened to that equilibrium yesterday.
Yeah, we had about, I think, 92 to 94 patients active in the hospital yesterday. Today we have 102 patients active in the hospital. More than 40% of those are in the ICU, with 46 in the ICU. But a large proportion of those, 30, are on the ventilator. So unfortunately, we still have a large number of recovering as well, 150. So our total number of acute and recovery is 152 patients.
That's a whole lot of folks.
That's a lot. Hays, I think is doing a little bit better from their active infections, but they do have 34 total people with 20 active and 14 recovering. So hopefully they've hit a plateau and can decrease. We, unfortunately, I think we are still being consistent with what we've said. Hospitalizations lag behind infections. And we know, luckily, over the past 5 or 6 days, we saw that maybe there's a peak in the total number of infections around the Kansas City metro area, but that could also be due to some slow or short data reporting because of the long weekend.
And I'm going to guess that's exactly right, along with less testing being done over the long weekend. Yeah. So, I'd gone out and a little bit about this over the weekend and had tried to do a few things for Christmas shopping, because I think this is a better time to do it than as you go later into the year. And as I did that, I thought, people are wearing a lot of masks. But then the flip side, we were talking just a little while ago that, man, a lot of Facebook posts of people getting together and the pictures from the airports, that was a little concerning.
Yeah, absolutely. And we know, and there were people just blatantly saying, I just wanted to go home, I didn't care. There was some good studies out, a good study out of Iceland kind of depicting that same thing, where they put the proportion of spread over time, and it looks like those social gatherings, not so much school, but those other places where people are getting together, where they aren't really necessarily wearing masks as they should be, distancing as they should be.
Yeah, so not necessarily in-person school, because they've done it at least as long as they've de-densified and they're wearing masks, but more the after-school gatherings, or any gatherings where people are together, is, I think, is really a concern. So, well, let's see if there's any questions from reporters before we jump in.
Good morning, Cody with Channel 9.
Hey, Cody.
Hope you both had a nice Thanksgiving weekend.
That was good. I hope you did too.
Thank you. As we get into the post-Thanksgiving stretch, and I know you talked about this a bit as a warning leading up to it, what's the timeline here? Are we starting to see, in your opinion, an uptick because of Thanksgiving, or will we see that in the next? I know you said it'd take 2 or 3 weeks maybe, but what's the concern moving into that phase now?
You bet. There are so many confounding variables. We'll kind of bat this one around a little bit. What I would first say is it's too early to actually see something from Thanksgiving, because normally it takes 2 to 5 days to incubate, or maybe a little bit longer in some folks, and so you're not going to get sick and be in the hospital for a few more days. So I think we're early to see a Thanksgiving wave. However, people did start traveling the week before Thanksgiving. There was a little bit more activity. It might be that, and colder weather, people moving indoors, lots of different variables around that. I'm going to guess that's it. I'm more worried about what Thanksgiving is going to do in another 10 to 14 days. I think between December 10th and December 14th, we'll know how that went. And then after that, because remember, a lot of the people that are traveling tend to be a little bit younger. Now, I think it's going to be a little different dynamic, though, than schools opening, right? Because when schools opened, Hawk, it took a while for that to really get into an older adult population, which are the ones that tend to come into the hospital. But I think Thanksgiving travel, while being younger in general, normal isn't like school. So we may skip one transmission generation, if you will, before we see the full impact of it. But I think that we really won't know until the 10th to 14th of December, and then really leading right up to Christmas, in which case we're going to have another wave from that time.
Yeah, absolutely. I don't think there's anything to add from that. You know, I was able to go out, get out and run on Friday. It was really nice here. There were still people who were outside and trying to do things, eat and gather in an outdoor setting. But as you said, as it does get colder, we know that people have gone through Thanksgiving now. They probably want to see friends again from that time until Christmas or even after Christmas. And so I think we are really heading for further infections, but we won't know for that 10 to 14 days, you know, from now or from Thanksgiving, just because of all those things that you mentioned.
Yeah, and there are also mitigating effects that we do that are hard to describe. There are more restrictions going on now. I do think people are doing a better job of wearing masks out in public and in shopping and in malls and places like that. I was out a little bit. I saw some of that. I was like, okay, that's pretty good. And schools are not in session. Again, I don't think it's the schools not in session. I think it's the after-school gathering and the socialization that's a bigger concern. Hard to know what's going on around with that. So I think that Cody, I think we're going to have to kind of ride the wave and see where it takes, but I suspect it's going to increase. I had hopes for stability. We'll see what happens with that. The Kansas City numbers, as we addressed, those look like they had flattened for 5 to 7 days, and even had if you look at it, was beginning to look like a hook, and the number was beginning to decline a little bit. And you thought, okay, that could be good news. But what we don't know is whether or not that is a testing issue over the holidays, and we'll have to wait and see what happens here at the beginning of the week.
Quick follow-up, if I can. I know Dr. Birx had basically said, look, if you did go to a Thanksgiving gathering, you need to treat yourself like you are infected, essentially. Do you agree with that? And maybe you could expound on that.
Huck, I'd say yes. What do you think?
Yeah, I think so. I think with the proportion of asymptomatic people that can spread the disease or pre-symptomatic people, you don't know if you are at a gathering and people had it. So I think that's a very smart way to go about things now after the Thanksgiving holiday. They also mentioned getting tested. We just don't have any real idea, real line on when you should get tested. I would say certainly nothing before 5 days from your last exposure, maybe in that week to 9 days or 10 days kind of place.
So let's say if you were at Thanksgiving dinner, then really you want to wait till maybe Tuesday of this week, or even Wednesday, I guess, even to really think about getting tested. 5 to 7 days at least afterwards. It was interesting the day that came out over the weekend, which we sort of talked about before, that your primary time of transmission is 2 days before the virus and 5 days after the virus. It's kind of locking that down pretty well, which they said drops off a lot after 5 days, which is sort of pushing toward that. We're rolling on quarantine for 7 to 10 days now.
Yeah, the CDC is considering. We heard a little bit of that last week. Again, it's just a consideration based on that. Certainly for the general population, those that aren't immunosuppressed, because we know immunosuppressed people can probably harbor more infectious virus longer. But for the general population, that is something that is being considered. But just as you said, really, those first couple days prior to any symptoms and those first few days after symptoms start is probably when you are most infectious.
Other questions?
Good morning, doctors. It's John Pepitone over at Fox 4.
Hey, John.
And good morning. I'm sorry if you've talked about this already. I missed the very beginning of the session, but I was wondering if I could get your reaction to the news that Moderna now is going to seek regulatory approval both in Europe and the United States for its vaccine, and we may have another vaccine available by the end of the year. If you could share some thoughts about that.
You bet. I think it's great news. I read about it. They came out with that late last night, early this morning, 94.1% effective, which is a great number. I mean, that's like eradication number with measles or smallpox or something like that. So we're excited about that. So I think it's great news. It's a little easier to transport and store than the Pfizer vaccine. And as I understand it, we will have, a number of doses that essentially double the capacity. So that all of that looked like good news to me, Hawk.
Yeah, it looks like it, and they've actually given us some numbers this time, and I think it was 15,000 people in the placebo arm, which is, again, they were using saline for this placebo, which is kind of fake drug, essentially. And then you had 15,000 people in the vaccine arm, and out of nearly 200 infections between those two, only 11 were in that vaccine arm. So we are starting to get actual numbers and data, and of course it looks safe. The thing we're also looking at is, does it then help reduce the chance that you can spread it to others? Because it does definitely look like it reduces the chance of hospitalization and severe illness as well.
Yeah, it would look like all the severe illnesses were in the placebo arm. The one death was in the placebo arm. Nobody who got the vaccine had to be hospitalized. And when you look at the number of people and the opportunities there, I think there are actually 160 severe infections that. So that's a pretty good, pretty darn good data, actually. Or 30 severe infections, 160 overall infections, and none of the severe infections were in Moderna's vaccine arm. So I think that's really good news, and I think that it portends well for that technology, which is a new, more innovative way for doing vaccine development, and something that we can develop pretty rapidly now that if this turns out to be proven. Also, the side effects didn't appear to be very severe. You know, muscle pain, fatigue, the same things you would get when you get the influenza vaccine. So I don't think that sounded too bad. So and it was effective. It appeared to be effective across all age groups and all types of people, whatever racial and ethnic background. So I think that I was happy with that.
Yeah.
We do want to see more data, especially the question about, are people infectious? If they get the vaccination, can they still transmit it? Because if we can drop that R naught down even further down under 1, that is great news with vaccination therapy.
Yep, lots of questions, but hopefully some of that will get answered when the official data is published. And they will have to give answers in some of those data for that EUA. But I think that's great. I think that's great. They said, 20 million doses by the end of December?
Yeah.
That's good. So that was another question is, well, which one should I pick? Well, you have to understand, too, that with the mass amount of people that we need to vaccinate, you need 1, 2, 3, maybe even 4 producers of these vaccines to get enough volume so that you can get the vaccinations out to the people.
Yeah, because this is only going to work if you have billions of people around the world getting the vaccinations.
Right.
You have to have all of them done. The good news about the AstraZeneca one, providing that the data will start to, once they kind of figure out some of their inconsistencies, very easy to transport that drug. So that'll, I think, be a really special advantage. Johnson & Johnson the same way. I've not heard about the J&J drug recently. Have you?
Not much, no. Not since, I think most recently this past week, the AstraZeneca, Moderna, and Pfizer taken a lot of the
Taking a lot of this stuff, yeah. So I think we're all excited. I think, the other thing that was interesting, the CDC said, okay, now we got to get real serious about who's going to get the drug. And so I think they're meeting this week to make their formal recommendation.
Meeting,
We've heard about 1A, 1B, Wave 2, Wave 3, but so I thought it had been pretty well developed, but it sounds like they're having an emergency meeting this week. And I suspect it's going to be based upon, all right, now that we've got this number of doses, now we have to figure out how to distribute that. Before, they didn't really know that. And so now here's the number of doses we're going to have. They're going to probably start around December the 15th. It's probably going to, because I think the first meeting is going to be December the 10th, right? There's one, then the 10th is going to be Pfizer. December 17th is going to be Moderna. As soon as they get their EUA, they're ready to ship, which they expect then we could start vaccinating somewhere between the 15th and 17th with the first round. So Merry Christmas, here it comes.
And I think I saw an article this weekend that a huge shipment of doses from Europe arrived in the United States already. So, and I can't remember what company that was, but they are getting ready.
These are exciting things. Okay. John, any other follow-up questions today?
I could follow up real quick. You mentioned the AstraZeneca vaccine, and there have been some questions raised about their conclusions or their effectiveness rate, the fact that they sort of mixed and matched the two different dosage levels to come up with the 70% effectiveness overall rate. And some people, I guess, are saying that they don't think that's realistic. Are you familiar with that, and what do you make of that controversy, if there is one there?
I'm going to speak out of both sides of my mouth for a minute. Sometimes science fumbles or bumbles onto discoveries. As I understand it, on the AstraZeneca trial, it was a mistake that led to half the dose on some patients. And I think they had 2,000 people who get that, and they did better than the people who got the full dose vaccine, which is that's kind of goofy. Makes everybody a little suspicious. It looks like it was a problem on the delivery end and not on the study design end. But nevertheless, there's a signal there. People don't know what that signal means, and so I think they're going to want to have more information.
Yeah.
At its lowest lowest level, it was 60% effective or 60-something percent effective, which is just right around and maybe a little better than influenza. So still something you'd want to do if you didn't have another vaccine available, I think, Hawk. But, man, I hope they can figure out that 80 or 90% effective level because, again, that's a game changer for a vaccine that's easy to distribute.
Yeah, absolutely. Again, just the media posts. But we would all like to see for all of these the actual data. And we know that safety is one of the top two concerns, safety and efficacy of the vaccine. So all of that will be transparent as well. And that's why we do have the FDA and the NIH and Operation Warp Speed all working together to make sure that those items are transparent so people can see the safety data as well as the efficacy data as well.
Nothing like published data to humble you and hear what the real opinions are.
Yes.
All these things look great, and then you publish the data, people start pouring over your statistics, and then you think the FDA would find all those flaws, but no, actually what happens in peer review is when things really, they turn out, because eyes that are not necessarily favorable look at your data, and they come up with different conclusions sometimes than you do. So here's what I would say about AstraZeneca. It's probably at least as effective as the influenza vaccine. It may not be as good as the one from Moderna and Pfizer, but we won't know until, as Hawk points out, we see the real data. And sometimes the best discoveries are by accident. So maybe they stumbled onto something that we wouldn't otherwise know. Other questions?
Gentlemen, it's Dan Cohen from 41 Action News. I wanted to ask you about mutation. I know there's been a lot of publications about the virus mutating. Do you guys have any concerns about that and how it relates to the vaccines that are currently in development and could potentially be approved?
You bet. The good news, Hawk, is that when it mutates, if it has indeed mutated, it looks like it did from perhaps very early on. The spike protein, which is the real problem, hasn't mutated. The vaccines are aimed at that. And as Deborah Birx and Fauci have both said, that makes it an easy target. If the spike protein mutates away, what do you got? You got regular coronavirus then.
Yeah, so we understand that with viruses, particularly RNA viruses, HIV is an RNA virus, their mutations happen because the reproduction of that viral particle is wrought with changes and differences. That's just the machinery that is making the virus. So we can see that really any one isolate of virus will have an average of 9 or so differences from another virus. This is just what happens in the replication of the virus in the body. But what we haven't seen is that there hasn't been any difference in the way coronavirus or SARS-CoV-2 affects the human body and causes disease with these mutations. There was another big mutation that was talked about, and it's actually a substitution of an amino acid, not part of the genome. It occurs because of a mutation in the genome, but it's more of a substitution in an amino acid.
The recording has stopped.
And that was for the spike protein and just a difference in that amino acid, which they say maybe became more easy to infect people, became more easy to reproduce more. But again, there is no clinically different isolation or isolate of the virus from when you go back to the Wuhan and the original isolates as well. So certainly mutations are always a problem and need to be accounted for. But right now, with as many mutations in the genome that people have identified through genomic analysis of a lot of isolates, there isn't anything that has shown to be really any clinical change from the original Wuhan isolate.
And again, the spike protein is the one that causes the problem as part of the virus and its expression of those genes. And the vaccinations are all aimed at that spike protein. So as long as the spike protein is around, A, that's going to determine pathogenicity of the virus, and B, that is the target of the immunization. And so I think because of that, if it mutates away, that's fine. We don't care if the spike protein leaves. Prefer it doesn't get replaced by anything worse, but that seems less likely. And so really I think the strategy around vaccination is still a very effective strategy because, if the spike protein leaves, then the virus will become much less pathogenic.
Yeah, and maybe if you're lucky and there's a mutation in the receptor binding domain, which is a lot of what our neutralizing antibodies are made up against.
And just to say, the receptor binding domain is a part of the spike protein that is binding to your body and helps open the door, if you will.
Yeah, and if you can't bind to that receptor on your body, I think that's a good thing. So we are always cognizant of mutations. We know they can occur. But again, right now we haven't seen any clinically distinct mutation in the infectious particles in the virus from really the original Wuhan strain.
Yeah, think about that receptor binding protein. Seems like a big word. Think about it as a door, right? Your body is a door and has a doorknob, and if you can open up the door, the bad things can get in. What happens with the spike protein is it's the arm, and the receptor binding protein is the hand that opens up the door with the doorknob. And so if that goes away, great. But in the meantime, we've got those vaccinations. The ones are all really work. The Moderna, the Pfizer, et cetera, are really aimed at that receptor binding protein area, and hence the way the virus can actually open the door. Other questions? All right, Jill.
Has a couple. Angie wants to know if someone traveled over the holiday, even though the CDC has not made official recommendations, what is the responsible thing to do?
Well, I think we heard it earlier today. You probably ought to go home, Hawk, and quarantine for somewhere between 5 and 10 days after you're done traveling.
Yeah. And then, again, if you know you're an exposure, there is a recommendation to get tested. They just haven't landed on when. But again, in this case as well, if you've traveled, isolate, quarantine for that 10 to 14 days. But also, if you really want to get tested, then I would say get tested at maybe that week mark. I certainly wouldn't do it any time before 5 days unless you're having symptoms.
And just to say, I think that all travel is not all travel. So what do you tell us what you think about the difference between being in a plane and being in a car right now?
Yeah, we definitely know, and we have said that car travel is more likely safer than not because you are with people in your household or you are alone. You're going to be able to stop off and get gas. That's an outdoor thing. If you do need to go into the convenience store, that's going to be a quick trip. You should be wearing your mask. Any food you can get is probably going to be takeout or drive-through. So that is much safer than, say, going through an airport where you have so many people traveling. And we know that there were a lot of people traveling this past weekend. Being in those confined spaces with other people, unable to, if you're unable to be physically distanced or masked, you should have had your mask on. And then air flight, again, in the plane itself. So, but I think we've always said that driving is much safer than flying.
Yeah, it's not traveling per se. It's what happens when you're traveling, and if you're going to gather with your family or whoever, whatever group you may have gathered with. And then I think going through the airport, man, those pictures, people were jammed in that airport, and I think that's a risk.
Channel 5 is also wanting to know that a few hospitals have come out and confirmed that they're very close on hospital bed capacity. He talks about St. Joseph at the time that he was typing this, that they had one bed, and they want to know, how are we doing?
Hawk, I over the weekend we were okay on beds because there weren't as many surgeries and things like that going on. So our census, I think yesterday was 625, which means we had beds. Now ICU beds are at a premium, and that's still a challenge for us, but we still had some ICU beds yesterday. I don't know that number today because we popped up so much overnight yesterday by adding the 10 or 12 COVID patients and not many COVID discharges. We're around 150, and that's a jump. We went up by 12 or 13 patients yesterday in total COVID numbers. So we'll see what the distribution is. As we talked about last week, we made plans to slow the ORs down especially toward the end of this week, and a lot of that's going to be based upon the capacity. But I think we're starting to bump up against it. I had some communication from a couple other hospital and health systems over the weekend. There's an email chain. We're all kind of checking in with each other to see how we're doing. And I think everybody's in basically the same boat that we're at right now here at KU. I think the other major hospitals are sort of in that same boat. And we'll know more. We have a chief medical officer called early this week, and we'll have a little bit more information at that point around it. But I think, capacity remains a major concern. Yep. And the real concern is going to be, this is our sickest time of the year, but between all the other things that people have. It also tends to be a busier time of the year as people try and get procedures and things done before their deductible has to restart again come January 1. And I think those things always make this a hard time, and now all the COVID. So it's gonna be busy.
Yeah, absolutely.
And last media question that I have is from Jordan at 41. She wants to know, after I've quarantined, should I go and get a physical?
Oh, what do you think?
If a person tested positive, should they be checked out?
If you're positive, or if you're not, you're just quarantined.
They were positive. They quarantined. That's over.
Got it. Okay. So what do you think?
Yeah, I don't think you need to go get a physical just for that, or get, if you have concerns and you still have some lingering symptoms, which we know occurs with so many COVID-19 patients, I would talk with your primary care physician or your medical team about those. But I think just going in to get an exam and get evaluated for some lingering symptoms, unless they are continuing to get worse and not getting any better, or if it's been a long time and you just need to have some encouragement and an evaluation for longer term symptoms, say, 3 or 4 or 5, 6 weeks out, then that's reasonable. But just understand that even with normal influenza or other cough and cold viruses, you can have some lingering symptoms for a couple weeks.
Yeah, I think that's right. And what about a high-performance athlete, somebody who's going to really push their heart rate and go to max capacity for exercise? I think you have to be able to, I definitely would urge you to call your primary care physician for that. If you feel any shortness of breath, any kind of palpitations, if you just don't feel right, don't rush back and try and go right back into things. There's a graded exercise program that has been evaluated and I think has worked very well for athletes who are returning to sports, because there are some concerns that happen in that situation. So be a little thoughtful about what your is. How are you feeling? I mean, if you feel completely normal and you don't feel bad, and that's true for a lot of folks, I think that's fine. Man, if you're a little short of breath, or you're having a little hard time breathing, or you're having a little chest discomfort, or any kind of your heart beating around sort of funny, you need to go have that evaluated before you do anything.
Yeah.
Okay.
All right, we're done with
All right,
questions.
let's turn to Rick Couldry.
Wow.
Rick, my gosh, we had a lot of questions this morning. You probably thought, what's going to happen? And Rachel, I guess we're going to start first with you. Tell us a little bit about how your team of 5 are holding up, and how's your lab equipment holding up? I know it's been getting a pretty big workout, and I think we grabbed a little video so people can see as you move around there, Rachel. So talk to us a little bit about your team.
Yeah, the team has grown a little bit. So we've added some individuals, some new faces in the lab, which is really exciting. And we're very busy. We're pretty tired. We've gotten some new instruments. We were here all through Thanksgiving, and we did about 1,500 tests over the course of the 4-day holiday, which is lower than kind of our normal days, but we continue testing through the holiday. So staying busy, but hanging in there.
And what has the demand for testing changed with the latest surge, or has it been pretty stable? And I know it's down low over the weekend, which concerns me because I think that's true around the city, which is why Kansas City is going to look a little lower. And I bet we see a spike now, or, oh, what happened? But I think it was all holiday effect. But prior to the holiday, would you say that you've experienced a lot more testing, or has it been pretty stable?
No, we've definitely seen an increase in demand and an increase in the number of tests that we perform. So in the last 4 weeks or so, we've probably doubled the average number of tests that we're doing. So a month ago, we were doing 600, 700, 800 a day. We're well over 1,000 a day, Monday through Friday these days. And continuing to have demand for testing to try to provide support, especially for areas of Kansas that don't have access to testing in the way that some of the individuals in the metro area do.
And so, Rachel, here's another question. So, there are a lot of different kind of tests out there. And we're a PCR, we're the old nasal swab, brain biopsy sort here. Tell us a little bit about your thoughts on some of the antigen testing, the saline testing, some of those other things.
Yeah, there's a lot of rapid antigen tests that are now available. I think that we are still waiting for really robust data. The tests seem to do pretty well in patients that are symptomatic. So if you're feeling symptoms and you get a negative, that's a relatively trustworthy test result. If you get a positive, certainly that's consistent. They don't perform as well, and we don't have a lot of data in the asymptomatic population. And so there's still some questions. We're waiting on some robust studies to understand that. I think in those individuals, we would recommend that if you do get a positive, then that be confirmed with a PCR. We've seen some patients as more and more antigen testing is performed in those asymptomatic groups where that positive, when we tested them by PCR, is not confirmed, and it's thought to be a false positive antigen test.
Yeah, it makes me concerned. I'm still a little nervous about some of their negative tests. So what about saliva testing? What are your thoughts around that one?
Saliva, there's some good data, again, in symptomatic and hospitalized patients, that saliva is a good specimen source. That's not really where the testing is aimed at this time. And we're in a little bit of a gray area, a data light area on how saliva performs in the asymptomatic group. We're working on some of those studies to try to contribute to a little bit of that knowledge. So I think that if you are positive in saliva, that's a reliable test. A negative seems to be pretty reliable in the data we've seen so far, but again, still trying to understand how that performs in an asymptomatic group of individuals.
Yeah. All right. Well, good luck, and thank you for your great work there. Rick Couldry, you got to be really proud of this team of people. Rachel's not talking about, man. She's got a heck of a team. They work all the time. How are the supplies holding up? How do you think your team's holding up?
Well, I think Rachel gave a great update, and she is our leader in the area and has contributed tremendously herself. Very humble, but we're very fortunate to have her on the team. And Steve, you asked about supplies, and the truth is, and this is I heard from Rachel just a few weeks ago. It's a week-to-week battle to make sure that the lab has all the things and all the supplies that they need to do the testing that needs to be done. So there's a lot of little things that don't seem apparent that other folks might not know about. For example, those little tips, you saw those in some of the videos, those little plastic tips, if we don't have those, you can't test. Swabs, media, all those kinds of things are things that the team has to track down. But they're a great group. They've done a great job from the beginning, and I know that they're in it to win it. So
I know we have some photos of the freezers, because that's a big deal with the Pfizer, and to some degree, not the same degree, no pun intended, maybe it was, about the Moderna vaccine. Talk to us a little bit about the work you've done to make sure we have capacity for freezing the vaccine or keeping it as cold as we were, and who all we're working with to do that.
Yeah, no problem. So it turns out that storing things at a negative 80 degrees Celsius isn't a normal thing to do for most of the rest of the world, but it is pretty normal in the healthcare world. So the lab has several of these freezers. The research community here on campus also has some of these freezers. The pharmacy has several of these freezers. And I think we're going to end up maybe purchasing one more new one. We're going to use it anyway. But just to make sure that we have enough frozen storage on hand for any of the vaccine that we might receive. And, Steve, you and Dana alluded to this a little bit. I think the challenge is as much storing the vaccine at frozen as it is the process for thawing it out. And then they come in, I believe the Pfizer vaccine comes in packs of 10. So you have to thaw out no less than 10 at a time in one vial. And then you have to have 10 patients to administer them to within 12 hours, or the vaccine is wasted. So we're going to have to manage that process really closely. I think that'll be a challenge for the clinical folks when we get going.
Well, I think the key is, just so everybody in our listening audience knows, you don't get a frozen vaccine. We let it warm to room temperature and then give it. But you don't have to worry about getting a frozen vaccine. And I say it's warm to room temperature. I think isn't it warm to room temperature? It's just not stable there very long, Hawk.
Or in the fridge, or just in a normal refrigerator.
Yeah. But it's not frozen.
No, it is not frozen.
Yeah, we do let it warm up a little bit. And by the way, Couldry, hey, dude, you know what? Over the Thanksgiving holiday, it looks like you shaved up here and you forgot to shave down here. Was that a turkey thing? I mean, did you get too much turkey? Did you lose contact? What happened with that?
This has been happening for a long time, Steve. It's not that new. So you can't grow hair here, so I'm growing it here. That's all that's happening. There you go.
All right, Jill, what questions do we have from our community listeners today?
Well, Val has a question about his brother who lives in Montana. He's 60, he's got cancer, and he's wanting to know and he's got COVID. He has two questions. One is, does COVID affect your cancer? And two, would he be a candidate for the monoclonal antibodies, and when should he go and get them?
Yeah, you bet. So as far as I know, Hawk, there is nothing around COVID that we know of, although it's really early, that actually affects the cancer directly.
Correct.
Indirectly, yes, because people delay getting care because they're afraid you'll get it and then cancer is presented at a later stage, or maybe they forget to get there and they don't go for their chemotherapy or whatever. So it affects it indirectly, but I've not seen anything about a direct effect. Have you?
Yeah, no, and what kind of cancer was it? I think it also matters. You know, if you have a blood cancer like a lymphoma or leukemia, we know that your immune system is probably not functioning normally, so you may be at higher risk of severe illness and critical illness. But as far as the monoclonal antibodies, you know, really it's going to be the biggest benefit if it is 7 days or less from when you had your symptoms onset. That's what that's in the EUA essentially. I think they use 10 days, but really a lot of the data is really 7 days or less from the symptom onset is when you're going to have the biggest benefit from the monoclonal antibodies.
Yeah. So do you think, if it had been within 7 days, would you recommend that somebody of that age with a history of cancer go ahead and get monoclonal antibody therapy?
Yeah, I think he would have been a good candidate for monoclonal. And again, this is to help reduce that viral stage of the disease that occurs within that first, 7 to 10 days after infection. It's where the virus is replicating. That's when you start to have a lot of the symptoms of the fevers, the aches, things of that nature. And then really after that 10, 12, 14 days, that's when we see the inflammatory process. So we really want to get it early in that viral stage to help decrease that viral replication.
And now there'll be both the Eli Lilly product and the Regeneron product. So we've got a couple of different choices.
Yep.
Not a lot of doses out there, but I do think, just to encourage people, if you are of anybody with underlying chronic disease, if you're over age 65, really ought to talk to your primary care physician, get a referral, because we have a hotline for at least the vaccine, the ones, the monoclonal antibodies that we have, that people can call and even be screened by an advanced practice provider who will work with them about whether or not they meet eligibility criteria. I think we ought to try and give this. I mean, our infusion centers are set up. We can do, I forgot, how many patients can we do a day right now?
We can do about 16 a day, and that's really where a lot of this stopgap is the amount that we can, not only the supply that we have, but the amount that we can do per day. And we have been using it because even Tuesday and Wednesday, everything was booked up. So we are giving it to patients, and we are actively screening and talking with patients to see if they would fit that criteria to be able to get it.
Yeah.
But there is in short supply. We know, I've seen other on email threads that there are some hospitals, locally within the region that aren't even giving it because they couldn't get through the systems and the protocols to be able to do it. So it is a very difficult infusion to give because you have to have a place where you can give it. You know that actively infected people are coming into your facility, so you have to take all those measures as well.
Oh, and he has chronic lymphatic leukemia.
Chronic lymphocytic leukemia. So you may. So again, we don't. I think it's just too early. Although we should ask Joel McGurk or one of our other leukemia experts about that. And so let's follow up on that question about can COVID directly affect the outcome of the leukemia? Let's see what he's thinking.
All right, we'll get Dr. McGurk on. Matt says he has a restaurant and his order of gloves was recently canceled. They were non-latex. I don't know if that makes a difference. He said he was told it was because where the gloves are made, not in the U.S., somewhere else, that the workers were getting sick. He's wanting to know if people getting sick is affecting what I would call supply chain.
Yeah, that is supply chain. Rick Couldry, you get involved with that question a lot. Is it affecting your side of the supply chain that people outside of KU are getting sick, or even inside KU are getting sick?
No one here has had any illness at all. I can't say that I know off the top of my head, Steve. We've had some shortage of materials in the lab, like I said, off and on, that the team has had to work through. We've managed to maintain all the medications. Dana's been involved in all that as well. And so we have not been directly infected, or we just have really outstanding team members who are able to find things even when there's been a shortage. But nothing that I can connect directly to the folks manufacturing having COVID.
I do know, I've heard that from other countries, that there are some shortages of supply chains on some medical equipment for this very purpose. And I think gloves, I've read about it, were one of them. N95 masks are another question, because I know there's been some supply chain issues that were not that related to people getting sick.
Yeah, and in fact, here at the health system, Kim Dixon, one of our good leaders, and Janie Ott help with the supply chain. We know that there is that problem. We are running into problems with gloves here at the health system as well. So it's not just commercial places, it's health systems as well. And this is what we've talked about when people say, oh, see, COVID's not that bad, not many people die from that. Well, we have talked about the death rate for sure, the mortality, but we've also talked about the number of people that are out in those other essential duties and those essential jobs, such as supply chain, such as making the goods and products that we need. We saw what happened when just 5% of the pork industry went down because of illness and what that did to our prices. You know, now we are talking about actual medical issues, and we've had this problem with N95s, just as you alluded to as well. So we know that in these very important essential businesses, such as medical supplies, but it's also in the people that protect us, the police officers, the firefighters, the EMTs, those types of situations as well, where COVID affects us on a daily basis. So it is very important. And again, it's not like the flu, and it's not just about the mortality. It's all those other things that can affect us in our everyday lives, in something as simple as gloves, whether that's for your restaurant or for the hospital.
All right, 2 more questions, Jill.
All right, Linda wants to know, why do you give ranges of 10 to 14 or 5 to 7? Shouldn't we just use 14 or 7?
Yeah, okay, Hawk, why a range? Because we don't know.
Because we don't know, and that is the truth. But what we do know is that really since the early days of the first published reports, the incubation period has been 14 days. But what are we talking about now? We know that the majority of people, based on the studies, who will have symptoms in that 5 to 7 day range after they have exposure. So that range is based on published data as well, because we are, you know, again, human bodies, everybody's different. Some people may get symptoms 2 days afterward, but the majority of people seems like they will get symptoms 5 to 7 days afterward. So if you are getting tested, and I think this is in response to getting tested after exposure, we want you to get tested when you will probably have the highest likelihood of having an accurate result, meaning that if you're positive, but if you're negative, you're probably negative for that time. But if you're in a quarantine situation, again, testing out of that quarantine for 14 days does not work. Even if you have a negative test, you need to make sure that you hold in that 14-day quarantine until and unless the CDC changes any of those recommendations. There's constant communication about that, but nothing has been done so far.
And
Jill,
last question, Susan wants to know, please explain the 90-day immunity.
The 90-day immunity, that's a good question, because it's hard to explain it, because we're not really even sure how long it lasts. There's mixed reports, because some people are saying, man, you actually may have some level of immunity for years, 2 or 3 years, and some people are saying, well, the antibody titers start to drop a little bit. But Hawk, there's more than one kind of immunity that we have. Yeah, and I think that's arbitrary too. That goes back to our last question, why 10 to 14 or things of that nature, because we really don't know. There has been heterogeneity in results of tests when they look at how high the antibodies titers are and how long they last. Some last a few weeks, some last 90 days or more. So I think that is different based on the different study designs of those studies. But just as you said, we hope that you have a memory response as well, and that is your memory B cells. Those are the specific cells in your immune system that create the antibodies toward SARS-CoV-2, and we know that you create many different antibodies towards SARS-CoV-2. Anything that looks foreign, your body will create antibodies to. But there's also those T cell responses. And so hopefully you will have memory T cells as well. That is the other immune system cell that helps fight off COVID. And hopefully you will have those clones of those cells that reside in your system for years, so that if you do see the virus again, you can mount a quicker response than the first time. And how will that manifest? Will it manifest as you not being infectious to others? Hopefully, but we don't know that for sure. And will it manifest as you having less risk of severe disease? Hopefully, but we have seen cases where some people get more symptoms and some people get less. So again, that is still an unanswered question. The 90 days, I think, is arbitrary, just based on some of those early studies showing the length or the duration of certain antibody titers within your body after you've seen or had the infection. And that's a pretty crude measure of your ability to respond to infection. So as we wind down today, Rachael Liesman, coming to you, what are you doing to keep your team safe? Because I know you're not sleeping.
No. Well, we are doing kind of all of the things that we're usually doing to keep our teams safe from getting COVID. So masking in the lab. It's hard to social distance in the lab, but we're doing the best that we can. I think more importantly, we are trying to keep morale up. We had a go live on a Friday, and we had an impromptu ribbon cutting, and sometimes we have cake. So mostly just trying to keep everybody's spirits up as we continue to do all of this testing and to help our community out and make it through the pandemic ourselves.
And Rachel, what is right now, tell us the most up-to-date thoughts about sensitivity and specificity for the PCR nasal swab biopsy that you like to run.
Yeah, so I think that all of the data has shown that this continues to be our gold standard. It is a very sensitive test. I think the clinical sensitivity probably is in the 80s, which is going to be pretty good. There has been a lot of questions about the specificity of the test, if patients are getting false positives. This is a very specific test. I think that the positives are certainly indicative that somebody has had an infection with SARS-CoV-2. Where in that infection process is difficult to determine with testing, but these are highly sensitive and highly specific tests. And I think that that's been shown repeatedly throughout the pandemic.
And Rachel, I just want to say a big thank you. You and your team have done remarkable work, and I don't know how to say it to our audience other than these guys have been one of the linchpins here in our health system and our ability to respond, and I think have helped a lot of programs around the area, the state, our community, and just been terrific. So Rachel, thank you. You've just been a tireless worker and leader, and you never stop. So thanks for your great work this pandemic. Rick Couldry,
absolutely.
You're also doing some work for the state now. I know we're trying to do a lot of testing, and we still have some capacity left.
So, if Rachel and I were in the studio together, she might throw things at me. But yes, we did agree to work with the state. And we have started helping with the city of Kansas testing. And actually, this is I think, a really great plan from the state government and KDHE, where they're taking federal funds to help support testing, and they have lined up many labs across the state of Kansas and set contracts with those labs. We're just one of the participating labs, and then assigned areas of the state that they want those labs to help support. So our lab was assigned a group of 5 counties in the central Kansas area, really focused mostly on long-term care facilities and retirement communities that don't necessarily have the testing that they need to help keep their guests and the folks they're caring for safe. So we've been contacted and started information gathering with about 44 facilities in those five counties. In addition to that, we've also worked really closely with a local FQHC called Vibrant, and we've already done over 1,000 tests for Vibrant, which serves Wyandotte County and citizens there who are underinsured or otherwise financially challenged. And so we've been able to already result over 1,000 tests with Vibrant for that community with support of the state. So I'm just kind of applauding the way the state has gone about this and reached out very, very quickly and established a network of labs to help improve testing through Kansas. And we're very proud to participate in that.
Well, thank you. And thanks for your great leadership and all the great work you and your team have done. So coming up tomorrow, Bob Mosier, the Dean of the School of Medicine in Salina, and David Wild, our Vice President of Performance Improvement, will update around the spread of the virus, its impact on communities and on learning, plus mitigation efforts to make room for patients we need to share that could be coming up here at the health system in the future. And remember, this discussion will focus a lot on rural area because Bob has been the former secretary at KDHE and is the Dean of the School of Medicine in Salina, as mentioned. So I think that'll be a great program. We'll have a lot of fun with that. And beginning next week, we go to the School of Vaccination, and that's going to be Vaccination 101. We'll start with on Monday, and we'll just get all the way to a level 5 course by Friday.
Yeah.
We're going to spend the whole week on vaccination.
That's right.
Yep.
Good.
Don't throw away your shot.
No,
so,
that's right.
Final thoughts.
Yeah, I would, I think having Rick and Rachel on today was great. We know Rachel has worked tirelessly. I think she was probably here at least 30 days in a row when it first started, trying to get all of our capacity up for testing, sleeping 2 to 3 hours a night probably, but she continues to work tirelessly. And I think testing is one of the ways that we are going to be able to get ourselves out of this, in addition to the public health guidance, the masking, the distancing, the not gathering in groups, and the vaccination. But testing is important. Right now, she continues to work tirelessly on what is going to be the best thing for the health system and our patients and our community. Currently, the gold standard, as she talked about, is that PCR test. As we find that there is a reliable antigen test to get more testing out for efficient results, we will certainly do that. But as of yet, I think we continue to stay with the gold standard, and Rachel is really leading that effort to get us to be able to test as many people as possible in the community, to understand really how far the disease is spread in the community, especially as we know there is a lot of spread in the community right now.
Thanks, Hawk. Hey, wanted to help you see a little bit about what some of our support staff do here on a daily basis. It's pretty cool stuff. We hope you enjoyed dinner with your family for Thanksgiving, and over the weekend I know I did, and we had a much smaller group gathering this year. We were down by about 80%. But I also wanted to share some video from people who seldom get to spend Thanksgiving with their family because they're here feeding our work family and our patients. Our support staff decided to offer Thanksgiving dinner and all the trimmings on Thursday and Friday, the special extended Thanksgiving. What better way to serve during a pandemic? But the ultimate way is to provide comfort food in the biggest holiday of the year. Here's what they did: 400 pounds of turkey, 152 pounds of ham, 136 pounds of stuffing. I think that means you're really stuffed. 80 pounds of mashed potatoes smothered in 80 gallons of gravy, 80 pounds of regular yams, plus 81 pounds of candied yams, 75 pounds of cranberry sauce, 120 pounds of green bean casserole, and 384 slices of pumpkin and apple pie. I had to breathe, plus 192 slices of chocolate cream pie. That's approximately a big number. So thanks a lot to our terrific staff and all the people who help make Thanksgiving special to the folks who are here. As we say goodbye, we join all Kansas and Missouri hospitals in asking you to be thankful to your community and protect that community by helping to wear a mask. We're going to show you a video. But before we go, I have not yet said today that the rules of infection control travel with you wherever you go. And I want you to remember that the rules of infection control travel with you wherever you go. And if you're going to try and stay safe, because vaccinations around the corner, monoclonal antibody therapies are here. Also, some big news of the weekend. We'll get to it tomorrow about some other novel therapies being developed. We're going to beat this darn thing, but in the meantime, you have the power. Let's take a look at this video.
My dad used to say, there's a difference between living in a place and being part of a community. If you're part of a community, you take responsibility for the health of your neighbors. Look, I don't like wearing a mask, but I love my community. And I'd do anything to save the life of a neighbor, a nurse, the kid who bags my groceries. Fortunately, all I have to do is this.